Welcome to the EP Edge October 2025 Issue 5. This is Dr. Sharma. Before we roll into the AI conversational segment, let's set the stage. We've come a long way in cardiac pacing, from right ventricular pacing to cardiac resynchronization therapy, and now to conduction system pacing. It all began with RV pacing. Life-saving, yes, but not physiologic. Over time, we learned that when RV pacing burden gets high, especially above 40%, it drives dysynchrony and adverse remodeling. Two early signals really shaped this story. In 2002, the David trial showed worse outcomes with more RV pacing. And in 2003, most trials confirmed patients with more than 40% pacing had higher heart failure events. Mechanistically, it's about a wide-paced QRS, an apical activation sequence, and the underlying substrate. Clinically, pacing-induced cardiomyopathy shows up in about 10 to 20% of patients over time. Meta-analyses peg it around 12%, with contemporary cohorts showing 6 to 20% within 10 years. Who's at risk? Wider-paced QRS, higher RV pacing percentage, lower baseline LVEF, male sex, intrinsic conduction disease, and apical lead position. To counter this dyssynchrony, we moved to biventricular pacing, CRT. It can be transformative, but here's the catch. Non-response rates hover around 30 to 40%. Why does CRT fail? Suboptimal LV lead location, scar burden, non-left bundle branch block patterns, AF with poor capture, timing issues, and challenging venous anatomy. A great therapy, but not universally physiologic. That's what pushed us to conduction system pacing, His bundle first, and now left bundle branch area pacing. The idea: recruit the native His Purkinje system and restore physiologic activation. Is it perfect? No. Implant. Success for left bundle area pacing is around 90% overall, meaning about 10% failure. And in heart failure populations, that number climbs closer to 18%. Larger LV size, broader QRS, and structural heart disease make it tougher. And while threshold rise or loss of capture is uncommon, it's not zero. So here's where we stand. We know why RV pacing matters, especially past that 40% threshold. We know why CRT sometimes falls short. And we now have CSP, which aims to bring us closer to true physiologic pacing while acknowledging its limitations. With that foundation set, let's jump into today's EP Edge discussion. This is an AI conversational narration of the EP Edge October newsletter, and as always, it has been personally vetted for accuracy.
Welcome to the Deep Dive. Today we're looking at sources pointing to a pretty big change in managing heart rhythms. It's all about left bundle branch area pacing, LBBP. Seems like it's really starting to outperform the older methods, like biventricular pacing or BVP. So our goal today is to kind of unpack why LBBP is gaining ground, and also look at the hurdles that still exist.
Yeah, absolutely. The core idea really is this move towards what's called physiologic pacing. You can think of BVP, the older method, like taking a detour around road construction. It works, but it's not ideal. LBBP, though, it aims to use the heart's own electrical highway, the His Purkinje system.
A natural wiring.
Exactly. So you get much better electrical synchrony. The timing is just more natural. And the clinical results, well, they really back that up.
Okay. So if it uses the heart's natural pathways better, why wasn't this the go-to method all along? Why did we stick with BVP for so long?
Well, mainly it was technical challenges. Getting the lead in the right spot is tricky. But the data piling up now is just so compelling. It makes tackling that learning curve really worthwhile. I mean, look at the clinical outcomes, especially serious arrhythmias. It's quite dramatic.
Okay, let's dive into that. What kind of numbers are we seeing?
So the ICLAS data, for example,
Right.
It showed sustained VTVFs. These are dangerous, life-threatening rhythms. The rate dropped way down.
How far down?
To about 4.2% with LBBF.
Yeah.
Compare that to 9.3% with BVP.
Wow, that's less than half. Significant.
It really is. And it's not just VTVF. We also see a drop in new onset atrial fibrillation, which can be really problematic.
Right, AFib. What were the numbers there?
About 2.8% for LBBP versus 6.6% for BVP. Again, a substantial difference. And it's not just about preventing bad rhythms. The mechanics look better, too, based on measurements.
Like the QRS duration.
Exactly. We see a narrower QRS duration. And for you listening, the QRS is basically the electrical footprint of the ventricles firing. Narrower means they're firing much more closely together in time. Better synchrony.
Which leads to better pumping function, presumably.
Precisely. Better reverse remodeling of the heart, and yes, significant improvement in left ventricular ejection fraction, or LVEF.
And maybe one of the biggest selling points isn't just the good things LBBA does, but also the bad thing it avoids. You mentioned the risk with standard RV pacing earlier.
Yes. The risk of pacing-induced cardiomyopathy, PICM. That's a real concern. Standard right ventricular pacing, just pacing the RV, can cause this chronic unnatural activation pattern. And maybe up to like 25% of patients could develop heart muscle weakness, cardiomyopathy because of it.
A quarter of patients, that's not insignificant.
Not at all. So LBBAP, by trying to preserve that natural activation pathway, it seems to really lower this PICM risk, which, translates to better long-term outcomes, especially for heart failure patients.
Okay, now this next bit from the sources, this felt like a real aha moment. The outcomes based on patient sex.
Oh, absolutely. This is something that really should shape how we approach patient selection moving forward. Specifically, women who have non-ischemic cardiomyopathy, so not caused by blockages, and left bundle branch block, they seem to get an incredibly strong benefit from LBBP.
How strong are we talking?
The data pointed to a 36% lower risk for the combined outcome of death or heart failure hospitalization in this specific group.
36% lower risk overall? But wasn't there an even more striking number for just hospitalizations?
Yes, that's right. For heart failure hospitalizations alone, a 60% reduction.
60%. Wow. For that group, LBB isn't just an option. It sounds like it should be the first option, the primary strategy.
You could certainly make that argument based on this data. It really highlights the importance of tailoring the therapy. But, while the physiology is superior, we do need to be realistic about the challenges. LBBAP isn't foolproof.
Right, the real-world application. As more centers adopt it, we're seeing some procedural issues pop up.
Exactly. It's a technically demanding procedure. You're guiding a lead quite precisely through the septum, that wall between the ventricles. And the sources do flag some worrying complication rates during this rapid adoption phase.
Like what?
Things like worsening tricuspid regurgitation, leakiness of the tricuspid valve reported in, up to maybe 32% in some series. And more concerning, perhaps, septal perforation, actually going through the wall in up to 14%.
Okay, those numbers are concerning. Why are these happening? Is it just technique?
It's partly technique, yes, but also the anatomy itself. The septum isn't uniform. It can be fibrous, scarred, complex. So actually failing to capture the conduction system effectively, that can happen in maybe 10-15% of cases, especially with difficult anatomy. Success really depends on careful technique and choosing the right patients.
So putting it all together, where does this leave us? LBB is clearly moving from just an alternative towards being a primary strategy, but overcoming these technical issues is key.
That's the crux of it. The future really depends on integrating better tools, like using advanced imaging during the procedure, maybe combined with EP mapping to really confirm you're in the perfect spot. That could reduce complications like perforation.
And the leads themselves.
That's the other big piece. We need innovation in the lead technology. Leads that are robust enough to handle being placed in this very specific mechanically active location long-term without failing.
So to wrap up, the sources are clear. LBBP offers some really compelling physiological advantages, reducing dangerous rhythms, potentially avoiding PICM, but
success hinges on mastering the technique and, importantly, on improving the technology to minimize those mechanical and procedural complications.
It really comes down to that interface between technology and biology.
It does. Maybe the thought to leave you, which is this. We're asking a sophisticated piece of hardware, a pacing lead, to maintain perfect electrical contact within a specific tiny area inside the heart muscle, a muscle that's constantly moving, contracting for potentially decades. Can our current lead designs truly withstand that kind of long-term mechanical stress in that precise location? That's the engineering challenge we absolutely have to solve to make LBBP the durable go-to standard for everyone who needs it.
And that wraps up today's discussion on left bundle branch area pacing. As we've seen, left bundle area pacing has evolved from an exciting concept to a reliable pacing strategy that's changing how we approach physiologic pacing. It's not the finish line, but it's a major step forward. If you'd like to dive deeper into the data, references, and infographics, you'll find it all in the full EP Edge October 2025 newsletter on LinkedIn. And thank you for listening. This is Dr. Niraj Sharma signing off for now. I'll see you in the next episode of EP Edge. Bye for now.